God. All right. Well, now that we've entertained everyone, we better get to work.
Yeah, exactly. Now it's time to actually do something. So welcome, everybody. Thanks for everybody for joining us. I know we'll probably still have a few other people show up, which is totally fine. There's a bit going on in the world, so I can imagine people are a bit distracted at the moment. So we're going to go through kind of our normal. We'll talk about some interval updates and changes to keep you guys abreast of. I know LJ hosted another webinar for the pediatric community the other night, so she'll give updates about that. And then obviously we will open it up for questions, and then also want to discuss our plans for next week, given the holiday and how we want to handle that process. So lots to cover, short amount of time. So we'll dive right in. It took almost 8 months to get to 9 million cases. It then took 13 days to get to 10 million cases, and it took 4 days to get to 11 million cases. So we are obviously not going in the right direction. 49 of 50 states are in the red progression, where they are having accelerations in case rates above what would be acceptable or what would be expected. So clearly it's really cross-cutting across the country. It's metropolitan areas, it's rural. It really has no respect for any particular boundaries at the moment. And you know, there's a slight sliver of hope locally that maybe that slight burst of warm weather that we had pulled us back from the edge a little bit. But obviously with colder weather and snow right outside my window, and Thanksgiving and indoor activities and lots of shared exposure coming, the fear is that we could take an even sharper turn on that exponential rise very quickly. So, you know, as you see here, the one thing I will call out, the reporting from Monroe County about the number that they've tested, they actually, for whatever reason, and I don't know if this is planned to be a permanent change, but they only reported the number that they tested in the last 24 hours. They're not reporting the total number of tested. I don't know if that was intentional. Obviously, one of the concerns that we had raised before, and I don't know if this is why, is that now with the plan to mix in the antigen testing that's going on in schools, that now we'd be combining different modalities, which before all the testing results that we were reporting were PCR based. I don't know if that's why they've decided to change the reporting, but today was the first time I've noticed that, quite honestly. So I don't have what the actual percent positive is. I will tell you that Dr. Mendoza last night, we had reached, and by his graphic actually had exceeded the 5% positivity rate. But in the last 2 days, we have now, by his data, now gone to below 4% positivity. We're trending at like 3.8, 3.9. So then that data supposedly was not including the screens that were happening at schools. So he just posted that last night. It was a Twitter post, so I don't have any more data to go on. But one of our greatest fears was that we were somewhat hurtling towards orange. No doubt, I think it was 700 hours of those tests were negative. So obviously that will increase the denominator and bring down the rate of positivity. But certainly our gross number of cases is still high. Our increase in hospitalization rate, as we'll talk in a moment, is still rising at a fairly rapid clip. And that's all concerning. The bit of good news for the moment, the average age for the hospitalized group has gone down a little bit. It also appears, whether it's because the age has gone down or whether it's just because of better management, that the proportion of patients that are in the ICU is lower than it was in the early days of the pandemic in the first wave. So there are some rays of hope in there, but certainly if the hospitalization rate were to continue on the trend that we were seeing for the last week or so, that could put us in a bad position very quickly. So, lots to take in here, but the infection rates are relatively high. New York State, interestingly, outside of Western New York, is actually doing better. So we're actually outpacing almost every other county in the state at this point, or at least were for a period of time. So, we'll see where that goes, but we and even Western New York, there's some expectation that Erie County is likely to go into the orange or even red in the next couple of days. They're anticipating it and kind of prepping for it. So still lots to address, lots of data heading not in the direction we'd like to see. But hopefully, people are going to take heed to this, and especially with Thanksgiving holiday, take on the responsibility and try to avoid large gatherings and the like. But I think we all know that there's going to be significant outcomes from that, most likely. The graphics, I'm not sure. The graphic for hospitalization is probably not as well suited. You can see this in the bottom right.
Oh, sorry. Which one do you want?
Back up 2 slides. That one.
This one?
Yep.
Okay, sorry.
No, that's good. So the graph in the bottom right, you can see that hospitalization, the blue curve, really starting to take a shift upwards. I think across the Finger Lakes region, I can't remember the total number of hospitalized. I want to say it was 256, 260, something like that. And then the total number of ICU is 40 at the moment. So pretty good volume on both. We'll show you in a minute for the U of R affiliates, but we've been gaining patients hospitalized or suspected of COVID at about 30 patients a day, which is much more rapid increase than what we were seeing even during the first wave of the pandemic or during the May timeline when we reached our peak hospital census. So that is certainly not heading in the direction that we would hope. I don't think the rest of these graphics are terribly hopeful, at least not for mine. That's bad. We'll see. So this again, Nick Apostolaris shares with us every week. So you can see kind of the surrounding counties. I actually was a little bit surprised to see that Erie actually isn't looking as bad as what they're advertising. So I don't know, the Monroe County data, again, keep in mind, it's a little bit of how you cut it. So oops, hold on, I'm sorry. Oh boy, I may have to pass the baton because they're wanting me over at MEC. So quickly, Erie County is supposedly at a higher rate than we are. The Monroe County data probably looks a little bit better if you look at the total number of tests obtained at the moment. Can I pass the baton, Renee and LJ, to you if I send you a shot of my agenda topics? I don't think there's anything that I know that you don't.
Sure.
Sorry.
Oh, you're testing my flexibility now. What the heck?
Hold on. Sorry, everybody.
Well, while we're waiting for Chad to send us stuff, I think 2 important things, and we'll mention this as well at the end of the meeting for people who are late arrivals. For next week for the holidays, because Thanksgiving is next week and we typically have this call on a Wednesday, we're actually going to move it to Tuesday. So we'll be putting that in the email this afternoon, and we'll send out a reminder as well. So this call, instead of Wednesday next week, will be Tuesday, which means that the behavioral health call that is typically held at lunchtime on Tuesday will not be happening at all next week. That will be canceled, and we will be providing that information in the daily email as well. So for next week, we will reconvene on Tuesday, but no behavioral health call. So there, I filled that empty air for you, Chad.
Sorry.
You're coming back?
I'll try to come back if I can. I think they only need me for a minute. I'm sorry.
Perfect. Okay.
All right. Bye.
So goodbye. So Renee, how about if I talk about the school stuff, since that's
great. Because
Chad's nice little handwritten agenda is hard for me to actually read on my phone right now. We'll piece that together. So I think you can stop screen sharing this data. So clearly we know that rates are going up. For those of you who did attend the community-wide call that was hosted by the Finger Lakes Schools Reopening Safely Task Force in collaboration with school administrators, school health office personnel, including nurses and school physicians, PAs and NPs, and then all of the healthcare providers. I'm just going to do a really quick skim through of a few of the slides from that, just hitting a couple of the high points. I'm going to try to answer some of the questions that came up on that forum and some questions that have been coming in from those of you who've been sending additional information in. And then I think what we will do is for about 5 minutes or so, just open for questions, Renee, if that's okay, because this is a smaller forum, we can actually do that. That's the hard thing about those big webinar things where you can't actually call on individuals and then everybody's posting their questions at the same time in the chat. Quite honestly, I find it a little stressful and overwhelming. So, so bear with me on this. I'm gonna share my screen. I need to get to the, whoa, that did not share right. Hold on, that was not the right screen share. Renee, feel free to vamp if you want for a minute while I get this up.
Sure. Well, nope, looks like you're gonna, nope. You gotta choose slideshow, LJ.
Yeah,
I'd put
yeah.
your,
That's what I had done, but it didn't work. So let me just try this. Oh my God. Let me just, something with my
that's
computer
okay,
is going
take your time.
wackadoodled.
I can cover pre-procedure testing
Perfect.
for the group. So some news about pre-procedure testing, as we talked about last week and as we put in the email, for procedures that are taking place at a UR Medicine facility or procedures that are taking place in the office for an AHP participating specialist, you can send patients for pre-procedure testing to those 4 locations on the document that we shared last week. Important to note is that, as we mentioned then, the patient must have the paper rec with them. They have to have a requisition form with them. We've had a couple instances of patients being turned away because they did not have the paper order. So just a reminder to please, for pre-procedure testing, make sure your patients have the paper requisition form. And for pre-procedure testing, it's limited to those 4 locations. They cannot just go to UR Medicine urgent care. They have to go to those 4 locations that were on that document, and we can repost that and re-up that information. Are you ready, LJ?
I'm trying one more time. I'm having like
Okay.
major technical difficulties with this, which I don't understand why. So I'm trying. Sorry about that.
Okay, nope, that's okay. Take your time. I still have various and sundry that I can go over. And while we're on the topic of pre-procedure testing, important thing to know is that for testing done or for procedures to be performed at UR Medicine, the test must be a PCR test, a nasopharyngeal PCR test. We've had reports of patients being sent to Rochester Regional for pre-procedure testing, and they are not doing an NP swab. And then the test had to be re-performed at UR Medicine. So best to keep your patients at UR Medicine testing locations for pre-procedure to ensure that they get the correct test so their scheduled procedure can happen.
Okay. Thanks, Renee. Do you have anything else you want to add to that?
That's good enough, LJ. We can see it. That looks good.
Okay, so I'm skimming through you guys, so apologize for the wild ride for a moment. What I wanted to just highlight for you guys is just one more time around the yellow zone and asymptomatic school testing and answer a couple specific questions that came up in that space. So I think one of the big things was the change in the governor's statement around this and the guidance around this that happened over the weekend. And I think it's really important that people do understand what this yellow zone testing is and what it is not. And initially, when the first guidance came out, I will be candid, I think most of us felt like this was a punishment for the schools and for kids who were trying to be in school and their families trying to send them for in-person school. It didn't make sense. The schools have been doing actually a really great job. We were not seeing, based on contact tracing, we weren't seeing spread in schools. And so it was very confusing why these very strict mandates around asymptomatic testing were happening. The other thing that people thought was, okay, this is a game. This is how we show our community rates are lower. And nobody likes to think of engaging their child in a testing thing that's a game. And so this new piece that came out from the governor was, I felt like, a bit of a game changer for us in terms of how we viewed this. The need to test students, asymptomatic testing in school and students and staff, now was restricted to 20% of the population of in-person students over a 2-week period. And if in that time frame, the schools were able to demonstrate that their level of prevalence was not what it was in the higher rates of prevalence we were seeing in the communities, they could then stop that testing. and they wouldn't have to keep doing this. The previous guidance was like this testing was going on and on and on forever. So I just would go back to what Chad said. This testing has been happening in schools now, in the public schools, definitely across Monroe County who were impacted by the yellow zone. I don't have any official knowledge or official documentation of how many tests have been done and what they have looked like. But we do know anecdotally, like Chad shared, in the first day in one district alone, over 600 tests were done and there were 0 positives. So we should be en route to be able to meet this pretty quickly. And I think that's something that's really important. And I know we all know, like we know that it's not being passed through schools, but this is validation of that through this asymptomatic testing. So we already talked about this. This is an antigen test. You know, this is in our community, we have said antigen tests are not the standard for symptomatic testing, right? They're not the gold standard. But in this case, if you're going to lift that level of testing, antigen testing is all that they have to be able to do. Parent consent is required. Parents can opt out, and the children are not restricted from school if a parent opts out and says they don't want their child tested. I think that's really important. The test is just a little bit of a Nere's swab. It is not the NP swab. It's very straightforward. The results are back in 15 minutes. What most of the schools are doing is letting parents know that they will be contacted if their child is positive. And obviously that child would need to come home from school at that point. I'm skipping to this. So this is the thing about an antigen test. There was a huge amount of debate with infectious disease, epidemiology, primary care, a number of people, lab directors, a number of people weighing in on this issue about this rapid antigen test. What's the positive predictive value, the negative predictive value? How many false positives might there actually be? So in the past, when we've talked about antigen testing, we have talked about the risk of a false negative, right? When in a symptomatic patient, your risk of a false negative is much greater. That's in a patient with symptoms. In a patient without symptoms, there is some risk of a false positive test. So what does that mean? We felt that despite there not being guidance from the state, and I'm saying like, not me, like this big collaborative group of people, that it was important to allow an option for families who wanted to back up that test, to have a backup test done that would be a PCR test. If their child tested positive at school, they would be able to get a backup PCR test. And that if there was a subsequent negative PCR test done within 48 hours of that initial antigen test from school, if there was a negative test, that would actually trump a positive antigen just by knowing the sensitivity and specificity of that test. So it is not a requirement if a child gets the testing at school, and we know this is obviously looking like it's a very small number of kids who have a positive test. A family can just take that result. The child would need to isolate, but then presumptively our understanding is that the county health department would ask for that family, then the close contacts in that family at a minimum would be in quarantine. So when you look at things from a population health level, this seems like, oh, it's not that many kids. When you look at it from an individual child and family level, this could be significant. So then we were struck by the problem, the fact that insurers do not cover asymptomatic testing. So this isn't a space where you could, as a primary care provider, just reassure a family, yeah, just come, we'll get that NP swab and that PCR test done here, and then it'll be a few days, but we'll get a result back and we'll see. We had to make it very clear to families that is not covered by insurance, so there's out-of-pocket cost. So what is being recommended as a workflow, as a first-line workflow, is for a child who has a positive test or a staff member who has a positive test at school, that they can then get this test repeated. That is clarifying that they really are asymptomatic. And the best place to do that to get a free test is going to be at MCC. If a family is willing to pay out of pocket, they want to come to an urgent care or they want to come to your office to get swabbed for that test, they can do that, but they have to understand there could be out-of-pocket cost. I think that's really the trick. This is just frustrating. And the main message I want to tell people is hopefully we are done with this within the next week or two, because what we're seeing is that the rates are significantly lower than what is in the general community. So this is what I would call like really imperfect, but it is the best that we can do with the information that we have to be thoughtful about this. The last point I want to make on this, if you look at the left arm here, rapid antigen test completed at school, boom, student or staff is determined to be symptomatic or to have had a high risk exposure within the past 14 days. That's a true positive, because then you've got these other qualifying criteria. You've got symptoms or you've got, you know, significant true exposure. Then that's positive, and the isolation and quarantine would go by guidelines. So I'm going to just stop for a second and just ask, Renee, are there things in the chat? I can't view the slides and read the chat at the same time for some reason. I can't do that. Are there things I need to answer about that?
Sure. So Genesis Peds is asking, what are the false positive and false negative rates for the antigen test?
It's about, so in an asymptomatic individual, the false positive rate is close to 20%. So like 1 out of 5 kids, right? 1 out of 5 of those tests could be a false positive.
Dr. Burchin's asking, who's ordering these tests?
So the tests that are happening in school, those test kits are being provided by the state. They are coming through the county to the school districts, and they are being administered at the school. So everything around parental consent and stuff for this is being done through the school. So anybody who has their kids in in-person school, in a public school, would have gotten this information. And I just want to qualify for the private and the charter schools. Some of them are doing this testing. There is the opportunity for them to do this testing. It's a little bit more complicated because I think just from for some of those private and charter schools, from a staffing standpoint, this has been a little bit more difficult. We are still hopeful that that testing can occur so that those kids can be in person. And we're working on, I know the county health department is working with the private schools and with the charter schools on this.
And then Nancy Balish asked, does insurance cover at places like Rite Aid, Walgreens? I have families going there. If they're not symptomatic but concerned that there may be an exposure, I think that's a no. It's still asymptomatic.
Yeah, it's asymptomatic. So families will end up with a bill for that.
Yeah. Because when a family thinks there's an exposure, really only the health department is the one determining if there's an exposure.
That's right.
Who says there's an exposure? Okay.
So it's contact tracing from the health department. But I think, some of the questions that appeared in the chat and some of the things that all of you have shared and we're well aware is it's taking longer to contact trace now. And this is not judgment passed on our health department teams. Like, they are working super hard to be efficient, but there's a lag time now. So I think, if we all understand, and if we can help our families to understand what true contact exposure means, there's a slide on this. I can certainly go through that, but it's 15 minutes. Our county health department is still holding with the 15 contiguous minutes spent in contact with someone who ultimately has now, has tested positive for COVID, where one or both of the individuals involved were not masked, and within 6 feet of each other, right? So it's all of those things. It's the distance, it's the time, and it's masking or not. So there are questions.
Nancy says the health department did say there's a positive case. So that to me would mean the health department should be coordinating that family's testing. It shouldn't be on their own, right?
Help me understand that question. I'm sorry, I don't understand the question because I'm not looking.
So there's a daycare. There has been a positive test. There's been a positive case, or case that has tested positive in the daycare, a parent. Mm-hmm. So the daycare notified everyone about it. There was nothing said that they had to get tested, but some parents felt that they should get tested.
Yeah, so I think this is the thing, cases are we're not eliminating cases of COVID, and cases of COVID are going to happen in children, and in adults. I think that it all depends on what were the processes that are being followed at that site, right? So if in the child care center, if they are following certain processes around whether it's Depends on the age. I don't know what age we're talking about, right? But if it's over 2 and kids are masked, if they're following certain procedures in terms of, how the kids are interacting with each other, how things are cleaned, et cetera, that may be mitigating for those families to not have to worry. And a test doesn't necessarily mean that much. It's the issue of quarantine. So the county health department will determine quarantine. So let me fast forward to a second, just to those slides real quick. So again, close contact we just talked about. What is quarantine for close contact? So quarantiners, people who don't have symptoms, and they don't actually need to be tested unless they develop symptoms. But if someone has been identified as a true close contact with a laboratory confirmed case of COVID, that means that they have to stay home. That's what quarantine is. And it's 14 days since the last exposure with the positive person. And there's nothing in this type of scenario around close contacts that gets you out of quarantine. It doesn't matter if you go and you get a test and you're negative. It doesn't matter if somebody says, oh, I don't think you need to do that. It's only the health department that should be removing people from quarantine in this space. And I think that's been a huge misconception in our community. There's the idea that, well, that doesn't really apply, or if I get a test and I don't have it, so I don't have to quarantine. Quarantine's all about shedding. So Nance, I can't answer that specific case about the childcare center because I'm not a contact tracer. I don't know the whole situation, but I know they go in and they look and they determine who would have been close contacts in that setting. Part of the reason why we've been saying schools are so safe is because even if there's been a positive case, and there have been positive cases of kids or teachers who've been in schools, when they look at the procedures followed, everybody is masked or they've been 6 feet apart and they've been doing the right things. So that means that's not close contact and they haven't seen spread in that situation. For whatever reason, there does seem to be less spread between younger children. Our kids have been in childcare throughout the whole pandemic, and we have not seen significant outbreaks in childcare centers as a general rule at all. And some of that may be some of that may be antibody protection because of all the other coronaviruses the kids get with multiple colds a year, and that there's some protective piece, or just the way this manifests in children differently. I think that the thing always in this is they do need to go back to the county health department and the county they are to get that assertion or yes, that's not the right word I'm coming up with. But anyway, to figure out if in fact somebody was a true close contact. Did that answer that question? Maybe. Renee, what other questions are in the chat? Oh, you're muted. Oh,
We've got some questions about telehealth. I don't know if I feel like we need to get through the school stuff though. I mean, there's no more questions about school.
Okay, so the only things I just want to point out really quick, two last things, I think. The guidance on travelers is different, and I think we're going to go through this, or this was on the agenda anyway to talk about this. This is why people are getting even more confused about quarantine, because how is it that somebody who traveled can get out of quarantine, but other people can't get out of quarantine? So if anybody asks you that question, it's the difference between traveling to an area where you might be at risk of more exposure versus being in close proximity with someone who tested positive, that you're considered a close contact. So just, I think if we can help people understand that, that's a really valuable thing. And then the last thing I just wanted to point out to you guys is that these two infographics in English and Spanish are going to be shared out at some point today to those of you who attended the forum. And I'm going to ask Renee if we can put them into our guidance that goes out today as well. This was a really nice opportunity for all practices and healthcare centers across our region to share the same information to kids and families as the schools are going to be doing, and just get people on board with the things that, the way to keep kids healthy is do what's happening in schools, but it applies at home, it applies in the community. It means kids shouldn't be having sleepovers, they shouldn't be having parties, they shouldn't be having gatherings where they're not outside or masked, or where you've put in these provisions to be careful. Everything we do outside of our work or our school is what's driving the increase in rates right now. And everybody's tired and everybody's frustrated, and we are social beings, and this doesn't feel right. But I think we have to be protective of our community, and we have to be protective of our own families as well. So I think we have to be a really big piece of this message, because no matter how many times County Executive Bello or Mike Mendoza get out and do their spiel, it feels like people are not embracing that it has to impact what happens on the outside. And I'm going to stop sharing and say the last thing is a question had come to me about what about outside play for kids? And, you know, I think that, again, I think we should be mindful at this point in time right now. It's just smart to mask. People and their kids, and kids wear masks way better than adults do, I think, is a general rule. Even the little ones, they kind of blow me away at how they, you know, they have their little multicolored mask and they're really proud of it. Some don't even want to take it off. Just mask. And then you eliminate so much of the risk, both in terms of transmission and in terms of receiving exposure to the virus. Okay, Renee, I'm turning it back to you unless there are other questions.
You're turning it back to me.
Oh, I thought
Okay.
I thought you said there were other things that needed to be, I'm sorry, I thought you had other things on your agenda.
No, well, there are items in the chat regarding, oh, we do have a question from Dr. Ingarowski. If a person is considered exposed to COVID and put in quarantine for 14 days but is never tested, how do we know that they did not become an asymptomatic positive and could thus spread COVID?
I think, Eric, it's a great question, but I think at this point that's why the quarantine is 14 days in part, and not just like 10 days, like the isolation piece for someone who's symptomatic. I think if they do develop symptoms, they do need to get tested, obviously, and that a positive test would extend, they would go into isolation then, right? They're no longer quarantined, then they're in isolation. And we use those terms interchangeably, and we're all really confused about it. But I think that it is felt that the relative risk of asymptomatic spread is so much lower that these guidelines are effective. So I think people have to be honest. You know, all of this relies on people being really honest, right? Honest about their symptoms, honest about where they spent their time, honest about, yeah, my kid was at that party and was unmasked and is a positive exposure, you know, not hiding this sort of stuff, because this all requires a lot of personal and social responsibility, and it's hard. So we just have to encourage people to be as honest in their reporting as possible. Eric, did that answer your question? I'm looking back to see if there are other questions in the chat there.
There is we do have some questions from Dr. Connors about telehealth, wanting to know if visits can be conducted only between RN and patient, or does it have to be an MD or PA in order to be paid? So the last guidance that we saw on that topic from Excelis indicated that there are telephone codes, and these are 98966 to 98968, which is telephone management of an established patient that can be done by a qualified health professional, does not need to be an MD. 99441 through 99443 must be an MD or an APP, a nurse practitioner or physician assistant. So those are all on our website. If you go to the COVID section and you choose payer information and then Excelis, that information can be found there. And then Dr. Connors also had a question about a U of R employee who was surrounded by 15 coworkers, all testing positive, was denied testing and told she had to work. We have tested her and awaiting results. Is this typical? I do know that it is employee health who makes the call about whether or not there was an actual exposure. And if there was, in their view, we'll send that employee, we'll take care of that employee's testing.
Thanks. And Renee, I'm seeing a question in the chat from Dr. Bauer. And Dr. Bauer, I'm going to ask if people will look in the messaging we sent out today. I'm going to try to clarify this question about what are the travel rules for staff. So if staff go out, if medical staff go out of the area and then are coming back, or if they've been out and they're coming back into the area, and we know what the travel guidance is right now about the 24 post-travel and 4-day post-travel tests. This whole thing around essential workers in this is a little bit confusing. So you're not the only team that's asking questions and is requesting clarification. So we're actually getting information both from the county as well as from URMC right now. I don't have that to present in a coherent fashion, but will within an hour or two. So I'm sorry I don't have that for you right now, but we will put that into the messaging that goes out today to be as clear as possible, because obviously this applies to every single one of you and your staff. And we want to be as clear as possible about that.
LJ, we had a question yesterday from Penfield Pediatrics. Maybe we can answer this on the call. It was regarding returning to PE class in Ontario County. They received a request that the student needs clearance to return to PE after quarantining. Other school districts are not requiring this additional documentation as far as we are aware. The Victor High School nurse states that the school physician is requiring a note from the patient's PCP in order to return to PE class, and that other physicians are writing notes without seeing the patient for a follow-up. This is where my confusion lies. Are these additional notes necessary for students to return to PE class in addition to the return to school document that's in use from the sample template provided by AHP? Obviously, LJ, I want you to answer it, but I will point out to Penfield Pediatrics that to say this is an Ontario County policy is probably not true, because we've certainly seen within individual counties, it's individual schools that seem to have different rules. So I would say this is, if you're answering it for Victor High School and not for Ontario County.
So I'm sharing my screen again. If I can make this happen well and effectively, let's see if this works, because I just want to go back to, that did work, thank goodness. I'm just going back to, whoops, there we go. You guys can see this. So this whole thing around return to sports is, again, confusing. The AAP put out guidance, the American Academy of Cardiology, American College of Cardiology, ooh, I messed that one up. Chad would laugh if he was on the call right now. They put out guidance around the potential risk for inflammation and myocarditis in children and in adolescents post-COVID. And within that guidance, there were general recommendations that basically state that someone who is post-COVID diagnosis, who's had a lab-confirmed COVID diagnosis, that they need to be asymptomatic for 14 days before they engage in rigorous activity, so sports or, PE. Patients who have had a true contact exposure and have been quarantined by the county also are restricted from participation for 14 days. Now, that one's a little easier because your quarantine is supposed to be 14 days. And if we're saying these are asymptomatic people in quarantine, then they've fulfilled the asymptomatic for 14 days. They fulfilled their quarantine and they can come back. Part of why we put out at least some general information about this to the community was because there was initially this perception like, holy cow, every kid's got to get an EKG in order to be able to come back and participate. And much of this guidance right now, with what is known about COVID from our vast experience since March, is that it's the kids who have more moderate symptoms or more severe symptoms that are at risk. And it's the kids over the age of 12 who are at more risk. So I'm just putting this flow diagram up again for you guys to look at. It is posted on our website. It is also available on the cardiology. It's at Galsano Children's on their referring provider landing page. We can send that link to if you want that. It's in multiple places, but moderate symptoms really means like prolonged fevers, with some significant symptomatic infection. Severe disease is, the kids who have MIS-C or have been hospitalized for this, which has not happened. We've had 9 hospitalized kids so far since March in our region here at Galsano Children's. So kids who are, this does not specifically require a note. The county, as they are releasing kids from isolation and from quarantine, are looking at this. And if they're releasing, if there's a concern where someone still has symptoms, then they are being referred to their PCP to follow with that patient to assure that symptoms resolve. But in general, there has not been a specific requirement for a PCP to see every kid who has had COVID or has been quarantined, it doesn't actually make sense. So there's not a specific requirement for a note unless it's a patient who the county, as they released from isolation, has concerns because they continue to have symptoms, and those kids and families are being notified that they cannot participate. Those kids alone who still have symptoms after the 10-day isolation period, that they would have follow-up to assure. Did that make sense? Okay. Can I make one
So
other
LJ,
comment real quick?
oh yeah, go ahead, of course.
There have been some really good suggestions from a lot of you to help in the communication with schools. And so we have asked for the administrative team with the task force to quickly collect fax numbers and phone numbers for all of the school health offices, the nurse offices, so that we can distribute that. And we're going to try to see if that can happen in the outlying counties as well, because we are encouraging a lot more communication back and forth, and we need to be able to do that because the rates change, our experience changes, the testing requirements change. So we want to make that more straightforward for all of you. The other thing is we are asking for the school nurses, and some school districts are already doing this, but we're trying to see if people can share what the positive symptoms were that generated, that necessitated a child being sent home from school. And that when they're coming to you, whether it's by televideo or whether in person, to be able to do your healthcare assessment, you have more information up front. You're not just relying on parent history. You actually know what those symptoms were to be able to address them. And I want to thank you all, because I think as a team, everybody has tried really hard to give good documentation back and forth between the schools and the healthcare providers, but we can do better. Look at Chad just came back to say goodbye. Whoa, Dr. Walsh has that list already. Woo, okay. Liz, you rock. We'll reach right out to you. That's fantastic. Okay, Chad, you get to say the final word.
Oh, I'm glad I could come back. Sorry. I was planning to present at MedExec today. I thought I was at the end of their meeting, and I got the "where the hell are you" text message. So I thought, oh, that's not good. And I guess they decided to move me to the beginning of the meeting. So lucky me. So tried not to get fired today. Hope everything went well. Sorry I had to run out all of a sudden.
So next week,
Chad, we covered, right. We covered the school stuff. We covered travel guidance. We talked about pre-procedure testing. We did not talk about the potential for, your inquiry into point of care, COVID, flu, RSV. We did not get to that.
So I can do that in 2 seconds if folks have a couple minutes. I realize we have 1 minute. So apropos to our conversation last week about the Cepheid and the Roche Liat platforms, I did reach out to the reps from both companies. It does appear that I know some of you already have a Cepheid platform. Great. The wait list to get a Cepheid platform is growing, and it's a minimum of 2 to 3 months, but likely longer at this point. And cost per test and time per result is longer and more expensive for the Cepheid than it is for the Roche. So I'm not knocking it, that's just the reality. So I reached out to the Roche. I had a very good conversation with the Roche rep. The COVID test, which is a COVID Cepheid test, is $70 for all 3 in 1. The Roche test is $43 for the COVID, $24 for the flu RSV. It's COVID flu, or $24 for the flu RSV. So roughly about the same cost if you want all 3. The Roche system is $10,000 for the desktop system. It is not currently planned to be made available until at least the end of the first quarter for practices. It's being planned for laboratory utilization or hospital utilization only. There is a window of opportunity where they are seemingly willing to treat AHP as a lab type customer, where we may have the ability to buy several systems at one time. Again, $10,000 per, there is no group discount, unfortunately. But we are, in fact, I'm supposed to speak to the Roche rep again this afternoon. It is potential that we could have access to the machines as early January. They didn't want to make promises they couldn't keep. But if there was such an interest, the question that I posed to you guys, and I realize we're out of time, so you can respond to me separately over email if it's easier. Number one, are you already doing testing and this is not beneficial to you? Number two, would you be interested if these machines came available in having a machine in your office? And then number three, if you can estimate what you think your weekly or monthly testing volume would be. I realize right now the first thought to your head would be $10,000 for something that tests for COVID only. I'm not sure it's valuable to me. The LEIT system also has the ability to do flu, RSV. By January, they'll be able to do C. diff and gonorrhea and chlamydia. They also can do strep amongst some other tests. So it's not a one-trick pony. It would have other rapid ID component. And the COVID result is 20 minutes processing. So I put it out there because I know testing has been a hot topic. The sensitivity specificity is on par with our current laboratory-based PCR platforms. And if that availability of those modalities comes available and you're interested, please reach out to me and let me know. That took 3 minutes, so I lied. Kill me. All right, so more to come on that. Happy to talk more to folks if they're interested. Just let me know.
So if we're at the end of the time and if there aren't any questions, I just want to remind people of what we mentioned earlier. Next week, our COVID call will be held on Tuesday instead of Wednesday. We will include that in today's email. We'll send you a reminder email next week. That consequently means that the behavioral health call for next week will not occur at all. That usually happens on Tuesdays. And for the Thanksgiving week, that call will be canceled. And again, we will remind you of that as well in today's email and next week. That's all I had.
I think that's all I got.
Take care, everybody. Thanks.
Sorry, everybody. Much appreciated.
Bye.
Sorry about the
Thanks,
mess.
guys.
It's Chad's
Take care.
fault.
Yep. I'm a mess of small fault. Talk to you guys soon. Thanks a
Bye.
lot. Bye-bye.